Today we will cover everything that you need to know about de-resuscitation. Why should we do de-resuscitation? Fluid administration is one of the most common therapeutic interventions in critical care. It carries high potential for harm as overzealous fluid resuscitation may lead to glycocalyx degradation and endothelial injury. Fluids should be regarded as drugs with specific indications, contraindications, and potential adverse effects. The renewed concept of fluid stewardship focuses on the 4 Ds: drug, dose, duration, and de-escalation. The 4 questions: when to start and when to stop fluid therapy, and when to start and when to stop fluid removal. The 4 indications: resuscitation, maintenance, replacement and nutrition. The conceptual Rose model describing 4 fluid phases: resuscitation, optimization, stabilization and evacuation. The term de-resuscitation was coined in 2014 and defined as active fluid removal in patients with fluid overload using drugs and/or ultrafiltration. Fluid accumulation denotes a pathologic state of overhydration associated with clinical impact and worse outcomes which may vary depending on age, comorbidity and phase of illness. It can be estimated by different methods: change in daily body weight, cumulative fluid balance, or bioelectrical impedance analysis with body composition. When to start de-resuscitation? As soon as salvage resuscitation has been completed, de-escalation should begin, aiming for a 0 fluid balance. Triggers include clinical signs, like increased weight, positive fluid balance, laboratory parameters, like hemodilution, radiological signs, like B-lines, pleural effusion, low inferior vena cava collapsibility index, altered cardiopulmonary function assessed by absence of fluid responsiveness, increased filling pressures and volumetric preload, low pulse pressure variation, and measures of end organ function can also guide us. The other tests that have been used and found useful are PLR test, extravascular lung water index, bioelectrical impedance vector analysis. Recently, the venous congestion by point-of-care ultrasound score gained attention as a technique to assess fluid status at the bedside. So next, how can we de-resuscitate? Start with metabolic optimization. Limit fluid intake, for example de-escalation of IV fluids when oral intake is possible. Use concentrated enteral formulas with 2 kilocalories per milliliter instead of 1 kilocalorie per milliliter. Limit sodium intake. Follow KDIGO-derived kidney care and treatment bundle. Clinicians should be aware that most fluids given are not given for resuscitation purposes, which is only 6%, but rather for maintenance, which is 25%, nutrition, 33%, and drug administration, or fluid creep, which is 33%. We can optimize fluid balance and prevent end organ injury by the use of vasodilator, inotropes, controlling intra-abdominal pressure. Active de-resuscitation can be done by combination therapy diuretics, application of PEEP, 20% albumin with diuretics, PAL treatment that is PEEP plus 20% albumin plus Lasix, SCUF, CVVHD with UF. Although excess fluid should be removed without hemodynamic compromise, occasionally it may be necessary to accept an increase in catecholamine support to facilitate fluid removal and improve critical physiological parameters such as oxygenation. When should we stop the de-resuscitation? De-resuscitation should be stopped when the goal is met, that is, benefit has been achieved, or when safety concerns arise. This goal can be fluid-related, which is a neutral balance, physiologic, like central venous pressure or CVP, or clinical, like improved oxygenation or extubation. However, there is no one single valid marker that indicates when euvolemia has been achieved. So the take-home message is, one of the most common interventions in critically ill patients is assessment of fluid status and prescription of fluid administration or removal. Both interventions have potential for harm and benefit, thus they should be regarded as drugs and managed according to the principles of fluid stewardship. De-resuscitation should never be too fast, too long or too aggressive. Deciding when to start and stop de-resuscitation is key to improving patient outcomes, and research is ongoing to identify the best parameters to guide fluid removal in critically ill patients. While waiting for the results of the RADAR 2 and CLASSIC trials, prevention of FA and de-escalation of fluid therapy remain the most effective strategies to avoid de-resuscitation. Give us a like if you found the video helpful. These are tables summarizing the therapies. Thank you.